Thank you for being here this morning. Professor Luca Ricceldi, Associate Professor of Respiratory Medicine and Director of the Center of Rare Lung Diseases at the University of Modena, Italy. Professor Luca will talk this morning about evolving concepts in diagnosis and treatment of idiopathic pulmonary fibrosis.
Thank you, Mr. Chairman, and thank you for the people attending to this early morning session on the Saturday, which is quite a challenge, I understand. But we will be discussing over the next 50 minutes about IPF in terms of how concepts are evolving in diagnosis and treatment of this disease. So what needs to be stressed initially is that IPF is certainly a prototype for rare lung disorders. For the reason that probably is the most frequent, although we think with sarcoid might be also very frequent, but certainly is the most deadly. So it's a disease with a very poor prognosis. And for this reason, many of the efforts in research, clinical research on the diagnostic and therapeutic side has been focused on IPF and not on other interstitial lung disease so far, which is going to happen, I think, in the next future. For this reason, in 2011, as you know very well, the Blue Journal published this document, which is the first global, because it's been endorsed by international societies around the world, document based on evidence dealing with the management of patients with IPF. And this document, as you see, has a multidisciplinary roster of authors, including pulmonologists, but also pathologists and radiologists, and we will see why it was there. And this has been used and will be used for the future clinical trials and for assessing the response to treatment in patients with IPF. So this document redefined, after 11 years from the first document in the year 2000, the way we define IPF. So how do we diagnose IPF as of today? So the diagnosis of IPF basically requires two major points. The first point is that we need to remind always that we are talking about an idiopathic disease. In order to define a disease as idiopathic, which means, as you know very well, without a known cause, we need to exclude all the known cause of interstitial lung disease. And this is not easy. For anyone working in the field will know that this is actually the critical step. Just to mention few of the factors that may confound the diagnosis of IPF, we have to think about environmental exposures. So chronic HP can very often mimic IPF, or we need to think about drug-induced interstitial lung disease, or we need to think about connective tissue disease-related ILD. And all of these factors, that can be obvious, can be an obvious exposure, can be asbestosis, can be something obvious, can be a drug that is clearly related to ILD, or can be more subtle. So now we are entering the area of the undefined connective tissue disease, so-called undifferentiated CTD, which are very difficult to define, and sometimes it's very difficult to understand if a patient has a connective tissue disease ongoing or not. But if, at the best of our knowledge, we exclude an existing cause of ILD, this is the first required for the diagnosis of IPF. Then the second pillar is the presence of a UIP pattern. What it means UIP? UIP is an old definition. It means usual interstitial pneumonia. Nobody knows actually why it's usual and not unusual, right? So it's just the definition of a pathological pattern on a surgical lung biopsy, and we will see the characteristic in a few minutes. It's just telling you that UIP is the correlate of IPF. But now the novelty of this guideline is that the UIP pattern can be defined on high-resolution CT scan. So far, the only UIP definition was on surgical lung biopsy. From now, the definition of surgical lung biopsy is on high-resolution CT scan too. That means that by a combination of clinical knowledge and some laboratory exams and high-resolution CT scan, we can make the diagnosis of IPF. In some patients, the diagnosis of UIP cannot be made on high-resolution CT scan. In that case, we will need a surgical lung biopsy in order to identify the UIP pattern. And in these patients, the combination of chest high-resolution CT scan and surgical lung biopsy will provide the diagnosis. So we estimate at the moment that probably around 50-60% of patients, they do not need a surgical lung biopsy. And it's important to understand that the previous criteria have been eliminated. So when you're in the presence of a typical UIP pattern on high-resolution CT scan, once you exclude all the known cause of ILD, you get the diagnosis of IPF. I'm sure that you will remember the major and minor criteria of the previous guideline. The previous guideline was published in year 2000, and just to give an example, one of the major criteria required for the diagnosis of IPF was a restrictive pattern on lung function. So now, lung function is not part of the definition of the diagnostic definition of IPF anymore. Because once you have a CT scan like this, it doesn't matter what your FVC tells you. It will be important for follow-up, but it's not important for the definition of the disease. And in the same way, age is not anymore a factor. You remember that the age of 50 was the cutoff, because younger than 50 you need a surgical lung biopsy. That's not true anymore, because if you have a patient which is younger than 50, excluding known cause of IPF, of interstitial lung disease, this high-resolution CT scan, that's going to be IPF. So the diagnostics is a little bit easier, but also is a little bit challenging in some time. Since the guideline is based on evidence, the guidelines needed to provide criteria to diagnose, to establish a UIP pattern on high-resolution CT scan. And we have three categories. The first category is the definite UIP pattern. If you have subpleural basal predominance of the lesions, reticular abnormality are present, honeycombing with or without traction bronchiectasis is present, and all these features are absent, then you get the typical UIP pattern. It means that these patients do not require a surgical lung biopsy. Why is that? Because we know that if you take a surgical lung biopsy in this patient, more than 95% of cases you will have a UIP pattern. So, in other words, once you exclude known causes ILD, to take a surgical lung biopsy in a patient with a definite UIP pattern, it's basically a mistake, because you are exposing your patient to a risk of surgery without any additional information. And you see, it's very clear-cut which are the factors, the features that actually do not stand for a UIP pattern, like upper predominance, peribronchovascular predominance, extensive ground glass, micronodules, cyst, mosaic attenuation, or consolidation. As you know, all of these, they point to either sarcoid or COP or an SIP, to other entity. But if all of them are absent and all of these three are present, then the sensitivity of radiology for a UIP pattern is extremely high. This category, since medicine is never black or white, fortunately or unfortunately, it depends, when you don't have honeycombing, so the absence of honeycombing, it makes the diagnosis of UIP on high-resolution CT scan only possible. It means that in order to achieve certainty about the diagnosis, you will need a surgical lung biopsy. Okay, so most of the patients with this pattern, they don't need anything else, and they will have IPF. When you take a biopsy in this group, around 50 to 60% they will have UIP, but the rest of the patient will have different pathology like NSIP or COP or chronic HP. So it's very clear that high-resolution CT scan changed the way we look at patients with interstitial lung disease, and in particular, pulmonologists are becoming a little bit chest radiologists. I'm sure that you want to have a look at the high-resolution CT scan of your patient, even if you have a good radiologist or even if you have some sort of response from your patient. And it's very easy. It's relatively easy to differentiate between patient with interstitial lung disease and healthy, in particular when you look at the lower zone of the lung. So honeycombing is the key. Why do we call it honeycombing? We call it honeycombing because the radiologists, they are like painter, they are like artists, so they tend to reflect the daily life in what they see in the CT scans. And they think, in fact it's true, that the appearance of diffuse cysts in different layers at the periphery of the lung actually is resembling the honeycombing of the bees, which is actually true and is a very evocative name. So the evocative name is telling you that if your radiologist will write the word honeycombing in his report, then you are allowed to make a diagnosis of IPF. If your radiologist is not picking up honeycombing, then you probably will need a surgical lung biopsy in your patient. So it makes a huge difference to have or not to have honeycombing. So the guideline reports 3 cases to clarify what they think are the categories. You see, always is important to have both projection on high-resolution CT scan, and in this case, you see it's very clear the presence of peripheral lesion, reticular, honeycombing is present, no ground glass, no nodules, no cysts. That's a definite UIP. This second case, again, you see the arrows point to honeycombing, which is peripheral, still is less evident than this one, but still it will be definite UIP because of the absence of the factors, characteristics that stand against the diagnosis of UIP. The third patient, actually without honeycombing, but with reticulation, with no ground glass, no cyst, no nodules, that's a possible UIP. So in these patients, again, if you want to achieve a conclusive diagnosis, you will need to take a surgical lung biopsy. Why? Because, just to remind you, only about 50% of these patients will have a UIP pattern at surgical lung biopsy. Of course, as we told, when high-resolution CT scan is not so clear-cut, you need a specific combination with surgical lung biopsy. Which lung biopsy? Again, here you remember that in the previous guideline, a bronchoscopy with BAL or transbronchial biopsy was required to exclude mainly sarcoid or other cause of ILD. Now, we know that based on current definition of UIP by pathologists, a transbronchial biopsy is not large enough to make the diagnosis of UIP. So, in other words, if you want to take a biopsy in a patient to identify the UIP pattern, transbronchial biopsies is not adequate. Why is that? Because UIP, by definition, is a heterogeneous disease. Heterogeneous means that at low power, under the microscope, you will see very different features. And if you take a transbronchial biopsy from a sample of UIP patient, you can have either normal lung, you can have dense fibrotic scars, which not provides you any information, or you can be lucky and you see the transition between the normal lung and the fibrotic scars with some fibroblastic foci. But that's happening very rarely. So in order to have the diagnostic criteria of spatial and temporal heterogeneity, you will need a surgical lung biopsy, preferably from multiple lobes. So once you decide to expose your patient to the risk of thoracic surgery, you will know that you want to achieve the maximum information from that surgery. That means you get a surgical lung biopsy from 2 or 3 lobes. Of course, as the radiologist, also the pathologist, they had to provide criteria to define the UIP pattern. And since pathologists are a little bit more evoluted, let's put it that way, or complicated than radiologists, now they don't have 3 categories, but they have 4 categories. I don't understand why it was not possible to come down to 3, but this is the way we are. So this first category is the equivalent of the UIP definite category in high-resolution CT scan. So if in your lung biopsy you see marked fibrosis plus minus honeycombing in subpleural paraseptal distribution, patchy involvement of the lung parenchyma and fibroblastic foci, and all the other features are absent, then you get a UIP pattern. And this is happening relatively frequently. Of course, again, the gray zone is there, even in the pathology, so it's still possible that with the surgical lung biopsy, you end up in a probable or possible UIP pattern. And then you will have a combination of high-resolution CT scan and surgical lung biopsy pathology to provide you the diagnosis of IPF or non-IPF. This is the example reported in the guidelines, and you will see very well that this disease is quite heterogeneous. And in the same biopsy, you have the coexistence of completely normal lung and completely distorted lung. And they have this area of transition from one to the other, which is considered to be where the epithelial and mesenchymal cells interact with the wrong message. So you can see micro honeycombing, and you have to see preserved lung. Both need to be present in the same sample. That's why you need a surgical lung biopsy. And at the higher power, you will have the chronic fibrosis and the hallmark of IPF, which is fibroblast focus, which is not specific, is not exclusive of IPF. It's not specific of UIP. It can be seen also in other disease, but in the right setting and in the right combination of normal lung and distorted lung, it makes the diagnosis of UIP. So which is the new diagnostic algorithm for IPF? First, you need to suspect the disease, and this is probably the major step worldwide. Still, we have many cases of patients that are not diagnosed with IPF simply because the physicians, they do not think about IPF. But once you know that IPF is there and is one possibility, then you need to ask yourself if there is an identifiable cause of interstitial lung disease. And again, to remind you that the 3 major categories of confounders for the diagnosis of IPF are connective tissue disease, drugs, and exposures. If you identify any of these, like you identify a scleroderma pattern, then it's not IPF. Because it can still be UIP, but it's not idiopathic. And this has a huge consequence in terms of therapy and in terms of prognosis. Of course, the therapy of a scleroderma lung and the prognosis of a scleroderma lung is completely different from the therapy and the prognosis of a patient with IPF. Still, it's important to know that the UIP pattern is not exclusive of IPF. If you take a biopsy in a patient with a scleroderma lung, most of the cases you will have a UIP pattern, but it's not idiopathic. If there is no identifiable cause, then high-resolution CT scan is the key, and if you are able to identify a UIP pattern in high-resolution CT scan, then the diagnosis is made. And these happen probably in about 60 to 70% of cases. So it's clear cut that the importance of a good radiologist here is important. If you are unable to identify the clear-cut pattern of UIP on high-resolution CT scan, and as we have seen, honeycombing is the key factor, then you need a surgical lung biopsy. And the surgical lung biopsy can provide you with a different diagnosis, like, let's say, NSIP, then it's not IPF, or will give you some information about the pattern, and then the decision of IPF or non-IPF has to be made through the multidisciplinary discussion. So at that stage, you need to involve your radiologist and your pathologist in order to achieve a confident diagnosis of IPF or non-IPF. Now, we will see that we are starting to have drugs specific for IPF. That's why to achieve the right diagnosis is extremely important. You don't want to treat a patient for a drug with IPF if the patient has not IPF, but most importantly, you don't want to miss a patient with IPF that can be treatable with an available drug if you are not able to go through this diagnostic procedure. So, honeycombing. Let me spend just a few moments on honeycombing. I see Professor Cordier sitting in the first row, so I have to discuss this. Honeycombing clearly is the most important finding in the radiological diagnosis of UIP in the context of IPF. And again, these are the three categories. And you will see that the only difference between category 1, definite UIP, and category 2, possible UIP, is the presence of honeycombing with or without traction bronchiectasis. So again, if your report from your radiologist use the word honeycombing, you can make the radiological diagnosis of IPF. If not, you can't. This paper has been just published in radiology. I think it's a very important paper, critical paper. It's made by radiologists. The core is from Japan. As you know, Japanese colleagues, they use radiology a lot, in particular high-resolution CT scan. But also the best radiologists, chest radiologists, are part of it, Martin Remy Jardin, or David Hanser, or David Lynch. They ask themselves, based on these new guidelines, how much the definition of, radiological definition of honeycombing is reliable when you look at inter-observer variability on high-resolution CT scan. And if you think that's a critical question, because your radiologist can be good, your radiologist can be very good, but it will always be one radiologist. What happens when you send the CT scan from your patient to a different hospital? That radiology will be good, can be even better, but how much they agree upon the definition of honeycombing? So the purpose of this study was the identification of agreement between observers in identifying honeycombing, and also to analyze which, if they are, the cause of disagreement in the identification of honeycombing high-resolution CT scan. And they defined 5 categories. I will briefly go through these 5 categories for you. And these 5 categories clearly capture the fact that honeycombing is, again, not a black or white definition, even if we have definition of honeycombing. So in this first patient, I think we will all agree that this is the typical case where definite honeycombing is present. And if you think to the definition of honeycombing, which is cysts, there can also be in single layer, but usually is a multiple layer, subpleural, peripheral, bilateral, then you'll see that this really is resembling the appearance of a true honeycombing. Right. So this is the extreme spectrum of definite honeycombing. Then when you move a little bit towards the less definite honeycombing, you have patients like this. And you're still using, yeah, there is honeycombing, but the definition of the cysts and the shape of the cysts are a little bit different. They change, they're more irregular, they have multiple layers, but sometimes it's just one layer, and so they define this as a probable honeycombing. So now we get into more complication, because the guidelines tells you honeycombing, no honeycombing. But that's probably not true, because again you have a gray zone and a graduation even in the radiological definition of honeycombing. And look at this patient. Okay, this patient looks like having honeycombing, but you see that the cysts are not precise, are not defined. These are larger, these are smaller, and here you think, how much of this is emphysema? And you get the definition of possible honeycombing. Then you get another patient, and this patient, again, the cysts are peripheral, are subpleural, but now they are more irregular, they change shape, they are larger, and they are not exactly subpleural. The subpleural space is preserved. Is this honeycombing or not? This is probably no honeycombing. It's a combination of emphysema, centrilobular emphysema and paraseptal, with some cysts, and then you get to the last category. When you look, it's just emphysema, right? But in theory, when you look at the definition of honeycombing, it might still honeycombing, but this definitely we know is not honeycombing, but it may look like in the hands of a non-expert radiologist. We agree it's centrilobular emphysema, but again, these cysts are peripheral, subpleural, different layers. So these are the results of the paper. They used a number of these CT scan, single image, taken from multiple patients, and they used those images selected by a core of radiologists to be scored by different radiologists in those different categories. And they have been very, very smart, because they used different group to define the concordance. See, they checked the concordance among local expert chest radiologists, specializing in diffuse lung disease, local chest radiologists with a specialty other than diffuse lung disease. They checked the concordance of local expert chest physician. They checked the concordance in local non-chest expert board certified radiologist. They look at North American expert chest radiologist, Korean expert chest radiologist, and European expert chest radiologist. So as you know, the kappa value is a value assessing the concordance among different readers on a set of predefined images. And the value of kappa goes from 0, no concordance at all, so anyone tells a different thing, to 1, which is full concordance. Now, if you look at the column on kappa value, the kappa value, unfortunately, ranges from 0.4 local non-chest expert board certified radiologist to 0.58 European expert chest radiologist. It means that even in the hands of expert chest radiologists from Europe, the maximum level of concordance is 0.6. So I think this paper underscored the fact that when you look at honeycombing with a critical and methodological appropriate approach, then to use the presence of honeycombing yes or no is not adequate. This is making things a little bit more complicated, maybe, but maybe it's telling us that we are oversimplifying the diagnosis of IPF and ILD, and we need some more strict definition of honeycombing, or maybe some more information. We maybe need molecular imaging, we maybe need different CT scan technique. But so far, with what we have, in the best hands of the best radiologists, the agreement in the definition of honeycombing is only marginal. So they discuss that the definition of honeycombing remains controversial when you look at that in the appropriate context, that they know that pathologically honeycombing represents destroyed and fibrotic lung tissue containing numerous cyst airspace with thick fibrous wall, but that's a pathological definition. And the Fleischner Society decided CT scan honeycombing only as clustered cystic airspace. And still there is some debate about if a single layer is honeycombing or you need a multi-layer to define honeycombing. And some of these factors, together with others, they can account for the reduced or, let's say, lower than ideal agreement in honeycombing. In practical terms, it means that when you have a patient and your radiologist report honeycombing, you take the same CT scan to a different radiologist, you have a significant chance that that patient, that radiologist would disagree. So, again, the best that we can do is to work with our radiologist and to try to have a consistent way of defining honeycombing in order to decide which patient should undergo lung biopsy and which patient should not. So, Mr. IPF basically is a 65-year-old man, former smoker with dyspnea on exertion, dry cough, normal air saturation when at rest, BMI a little bit more than normal, bibasilar Verker type cracker. This is very important and relatively non-explored in, I say in a systematic way finding. Prominent P2, they can have some pulmonary hypertension. PFT will show a mixed restriction obstruction but with a low DLCO, and previously has been usually diagnosed as COPD. We have seen yesterday that the prognosis of this patient is similar to the prognosis of patient with lung cancer. So it's important, critically important to find this patient. What about therapy? So in the last 20 minutes I will just to update on what's new or what's ongoing on therapy of IPF. Again, in year 2000, this group of experts, including Professor Cordier, they provided us with the best at that time recommendation. That was, again, we need to read carefully what they read, because the starting of this paragraph, I think, is of paramount importance. They write, until adequate studies are conducted. That means that in year 2000, we do not have adequate studies. And this therapy was just the reflection of the current, at year 2000, concept on the pathogenesis of the disease. In year 2000, we thought that IPF was a mix of an inflammatory and immune-mediated disorder. For this reason, it would make a lot of sense to prescribe this patient a combination of corticosteroids and immunosuppressors. So these guidelines were not based on evidence, they were not studied enough, and it was very clear from the statement of the authors, but still they were very much followed. This is a survey among US physicians treating patients with IPF, with both mild and moderate IPF, and you will see that most of the physicians, they did follow those guidelines, which is good. It's good practice. Of course, they add NAC because of the Iphigenia trial. Subsequent, you see, but most of the patients, independent from the grade of severity of the disease, they have been treated with the combination of corticosteroids and immunosuppressor. In part, this was because the guideline recommended that, but in part also because these are drugs which are widely available, inexpensive, although they have never been approved for use in IPF. Corticosteroids and immunosuppressors have never been registered for IPF. That means that all of these treatments were what we call now off-label treatments. Corticosteroids, we knew after some years of use that basically there was no evidence for their use. But why they were so used? When I visited Moises Selman in Mexico last year, and they tend to have the Mexican Respiratory Society meeting in nice place like this one. This was in Cancun. I was walking in Cancun one afternoon, and I did see these drug stores. They're very common in the US, in North America. They're not very common in Europe. I don't know about Lebanon, but you can buy drugs freely, right? And basically, from what they advertise, you will see which are the most widely used drugs freely from patients. Of course, there are antibiotics, which make a lot of sense. Okay, diuretics, again, important mainstream. Antidepressants, that's also important, even in Mexico. But corticosteroids were clearly the most widely used drugs, and they have different formulation, different forms, different dosage, any pill, any cream, any lotion, steroids were really, that means that the use of corticosteroid has been so large, first because it was recommended by guidelines, but also because as a pulmonologist, when we don't know what to use, we use corticosteroid. And that's true of any physician, not only of pulmonologists. By the way, I was also impressed by how they pay attention to pulmonary hypertension, right? Although I'm not sure they use it for pulmonary hypertension. In any case, we know now, by performing the studies that the experts in year 2000 considered not being available, we know now a little bit more about the treatment of this disease. And in particular, these studies, the so-called PANTHER trial that was published last year, assessed the effect of the so-called triple therapy in patients with IPF. So, as you know very well, this study was stopped early at about 50% of recruitment because an interim pre-planned analysis showed two things. The first one is that patients on triple therapy, they died more than patients on placebo. And that was really shocking because it means that by using a combination of corticosteroids, azathioprine, and NAC, we increase the mortality of patients with IPF without any effect on disease progression, but with an increase in hospitalization or time to death. We still do not have a clear-cut explanation for this finding, but I think that these findings are crucially important to let us understand that the disease is not susceptible of treatment by the use of anti-inflammatory and immunomodulatory drugs, and probably there is something in the pathogenesis of the disease that has not been picked up yet that is actually making this drug more harmful than of benefit for patients with IPF. So clearly after year 2000, there has been a huge increase in the number of randomized controlled trials in IPF. You see, these are all the randomized controlled trial, placebo controlled, that have been published so far, and the size of the square is proportional to the number of patients enrolled. So if you look up to year 2000, there was few studies, very small, on few patients. And when the industry basically entered the field, and the IPF net entered the field, you see that the size of the studies has been increased, and so the quality of the information that we had from these trials. For this reason, it was possible to provide recommendation in these guidelines, and I'm sure that you know that evidence-based recommendations from these guidelines are relatively disappointing. because there is no recommendation in favor of any pharmacological treatment. There is a recommendation in favor of intervention like oxygen in patients with significant resting hypoxemia, or lung transplantation in the appropriate patients, of course, or corticosteroids for acute exacerbation of IPF, even in the absence of evidence, or pulmonary rehab, again with very little evidence. But what is more disappointing is that for most, if not all, of the pharmacological options that have been tested in IPF, basically the recommendation was against the use, either strongly or weakly, but against the use. After the publication of the guidelines, further studies have been presented or published. So the PANTHER trial is one. We have seen already that now the triple therapy will probably receive a strong recommendation against use in the next update of the guidelines. But even anticoagulants, this is a second IPF-NET study, they tried to compare warfarin with placebo in patients with IPF, and even this study was stopped early, and the stop early of this study was based on the fact that the primary endpoint was negative at the interim analysis, and you see the primary endpoint was a combination of all-cause mortality, hospitalization, or decrease in FVC more than 10%. But again, there was a harm signal here because all-cause mortality was higher in the limb treated with warfarin as compared to placebo. And that was also true for all-cause hospitalization and all-cause mortality. You see the patient in the blue line treated with warfarin, they die more and they are more hospitalized than patient in the placebo arm. So a further study suggesting that in these patients is not only that we do not make benefit with some treatment, but actually we can make harms. Pirfenidone is another option. Again, the guidelines recommend the weak recommendation against the use of pirfenidone. These data have been considered by the guidelines, but they were not published at the time of the publication of the guidelines. I'm sure that you are aware of the two so-called capacity trials. These trials are parallel trials exploring the effect of pirfenidone high and low dose as compared to placebo over a span time of long period of time of 72 weeks, 1.5 years. Now, you see the primary endpoint was a decline in forced vital capacity, and you can see here that compared to the decline in the placebo arm, which is the green one, both the low dose and the high dose pirfenidone reduced the rate of decline of FVC in one trial, but that was not seen in the other trial. This is the largest trial comparing only placebo and high dose pirfenidone, and although the difference was there at 48 weeks, at 72 weeks the two arms were not different in terms of FVC. When you combine these two studies, you still see some signal, right? So it seems like by combining the two studies, pirfenidone slowed down the progression of FVC decline over 72 weeks as compared to patients in the placebo arm. And when you look at additional data from Japan, there is another phase 3 trial that was not considered by the guidelines, and you combine them in a meta-analysis with having the primary endpoint of a sort of progression-free survival like we use in cancer, which is a combination of either a 10% decline in FVC or death, you see that by using pirfenidone, the progression-free survival is increased by 30%, and that's statistically significant. So based on this data, pirfenidone was approved, is the first drug approved for IPF in Europe, is available in most countries in Europe now, is available in India, is available in Japan, and is slowly entering clinical practice, and we learn more and more about this drug as long as we are using this. This has not been approved in the US. The reason for this are various and different. We can discuss that. Is a combination of different views from different agencies and the way they look at the randomized control data and when they consider the randomized control data as of sufficient quality for being part of an assessment or not. In fact, the FDA did not consider the Japanese data because they did not consider theirs of sufficient quality. But this ASCEND trial is actually completed enrollment, is a placebo-controlled trial comparing high-dose pirfenidone with placebo, 52 weeks, and the data are going to be presented to the next ATS meeting in 2014. Now, we have seen that the history of treatments of IPF has been a mix of unexpected results, disappointing results, or something that was not really expected. Why is that? I think this is the reflection of the fact that our concept on the pathogenesis of pulmonary fibrosis is quickly changing over time. This is a review that has been published by the group of Paul Noble last year in JCI. I think is highlighting very well how much we change our concept of the basic mechanisms which are responsible for pulmonary fibrosis. Again, this is the cartoon that you will not have seen 10 years ago. The current concept of pulmonary fibrosis is that environmental insults, including viral infection and smoking, and genetic predisposition, which is becoming more and more clear in patients with IPF in different studies, they all contribute to the major dysfunction in pulmonary fibrosis, which is at the level of the epithelial cells. And these epithelial cells, through the mechanism of endothelial reticulum stress, they go into apoptosis, which is now considered the major factor involved in the generation of honeycombing. And on the other side, senescence mechanism. Just remind that IPF is a disease of senescence. They go to the production of fibrosis, and these two factors, they will interact. So, from this cartoon is very clear how the drugs like corticosteroids or immunosuppressor or anticoagulants or even drugs with some antifibrotic, they will not have any chance of being effective in these patients, but probably by increasing side effects, they will just increase mortality and hospitalization. And if you look in more detail, you will see that basically IPF and pulmonary fibrosis now is considered to be a fibroproliferative disorder in which you have the crosstalk between the epithelial cells and the mesenchymal cells. They produce matrix deposition and fibrosis. So most of the drugs that have been tested so far, they did not target any of these mechanisms. I will just draw your attention on recent data published on IPF on a category of drugs that maybe 10-15 years ago we'd never thought about using in a disease like IPF. I'm sure that you know that tyrosine kinases are extremely important enzymes because they catalyze the transfer of phosphatase from ATP to tyrosine residues in polypeptide. So they are critically important enzymes. There are about 90 tyrosine kinases in the human DNA, and they all contribute to proliferation of cells, survival, apoptosis, differentiation, function, and motility. So these molecules have been the target of a huge pharmacological research. and you see how many drugs now have been used. And they are differentiated in non-receptor inhibitors or receptor inhibitors, okay? But that doesn't make a difference. All of these drugs, they have been used and tested mainly in oncology. And some of these drugs, I'm sure you know, they actually change the history of some disease, like imatinib or dasatinib or afatinib that we use now in lung cancer. So all of them, they are important, and they have been mostly used in cancer. This molecule in particular is a tyrosine kinase inhibitor that targets multiple kinases, and in particular targets one kinase, which is important, is considered to be important for the metastatic process in cancer. It's VEGF, is vascular endothelial growth factor receptor 2. And the company decided to explore the potential of this drug in IPF. So now here is a change of paradigm. When some experts think that a particular mechanism of action of a disease or a class of molecules that was considered to be peculiar of one area, which is oncology, now can be transferred to a non-oncology area. This was not possible some years ago because the department in the companies were very strict. You have the oncology, you have inflammation, you have anti-infectious, and so on. Now that the mechanisms are switching from one disease to the other, they start switching molecules from one side to the other. That's why they started with this drug. The name was at the time BIBF 1120, and they tried this drug in animal models. And they have seen that in animal models of fibrosis, of lung fibrosis, VEGF, PDGF, and FGF are highly expressed. And by blocking the receptor, maybe this drug can be useful in reducing progression of IPF. And the results of the phase 2 of this trial, they have been published in 2011. Of course, this was a phase 2 trial, so it was dose finding, safety. So we tested multiple doses of the drug in a relatively limited number of patients compared to placebo for 1 year. And these are the results of the primary endpoint for efficacy, forced vital capacity. These are the placebo arm, and as we know, the typical IPF patient will be losing about 200 milliliters of FVC over 1 year. That's consistent over different trials. When you look at what is considered to be the active dose of the drug, the relative reduction is about 70%. So it seems like this drug actually is lowering the progression of disease, but not only this, we had very positive signal on secondary endpoint. Look at the rate of decline over time of FVC, and if you isolate the placebo arm and the high dose arm, it seems like this drug over 1 year tends to stabilize lung function in patients with IPF. But not only, it reduced dramatically the rate of acute exacerbation. You know, acute exacerbation in IPF is not like acute exacerbation in COPD. They have 80% mortality. So while in the placebo arm, 16% of patients experience at least one acute exacerbation, in the treated arm with the higher dose, only 2% of them get acute exacerbation. And surprisingly, these patients treated with an anti-cancer drug, they reported better quality of life. So, you know, this is the St. John's Respiratory Questionnaire. Everything going up is worse quality of life. Everything going down is better quality of life. So these patients tend to stabilize the quality of life. And that was mainly reduction of dyspnea and reduction of cough. So based on these data, now 2 large phase 3 trials have been initiated immediately by the company. And now these trials, they were worldwide. They enrolled patients all over the world. They enrolled more than 1,000 patients with IPF as defined by the current guidelines. 52 weeks, placebo control, The primary endpoint, again, is change in forced vital capacity. The results are expected later this year and will be presented at ATS in 2014. So we will know from this trial if the drug is effective. But just to tell you that the change in the pathogenesis prompted to the testing of many different drugs in different environments. And see, these are just probably not a complete list of all the molecules either in phase 1, phase 2, or phase 2, phase 3. And you see in particular, looking at this column, how different are the target of these molecules. That means that it's very likely that in the near future we are going to treat these patients with a combination of molecules, and many of these molecules are targeting factors that might be involved in pulmonary fibrosis, but we did not think about that before. Chemokine, T-cell receptor, or even antioxidants, or type 5 collagen or pentraxin, they are all new targets. So the horizon is bright. We hope that we'll have good news for the patient with IPF. So far we have the first drug approved, and with this I thank you for your attention.
Thank you, Professor Luca. Time for question, please.
Well, thank you very much, Luca, for this very comprehensive review on the challenges of IPF in this time. I feel it is very important that the diagnostic criteria are well interpreted. And especially, it is very easy for everybody to make a diagnosis of very advanced IPF with multi-layer honeycombing. However, most of the problem is the early diagnosis of disease, and especially when there is no honeycombing. And it has become the practice in many countries, and especially in France, that when chest physicians see patients with interstitial lung disease, they do not ask for lung biopsy. They are somewhat waiting for honeycombing appears, and then they say, well, it is truly IPF, but it is too late. And I feel that especially since there are drugs which seem to be promising, our main objective should be to diagnose very early idiopathic pulmonary fibrosis. And this is some kind of change of paradigm in the diagnosis, because making a lung biopsy in a patient with a good condition and not that much deteriorated lung function test is not dangerous. And it should be promoted that lung biopsy is made earlier than it has been in the past. And I feel it is an important message which becomes mandatory at the time when drugs appear. When there were no drugs available working on IPF, late diagnosis was not a problem. But I feel it is now, and I feel that our job for pulmonologists is to tell people, and especially the GP, that the early diagnosis of IPF should be a challenge for the forthcoming years.
I cannot agree more with the comment from Jean-François. It's really challenging, and one of the few things that we know about IPF, which is honeycombing, is irreversible. So that's clearly too late. I agree with you.
Just regarding the biopsy, what about the conflictual data about the triggering effect on fibrosis?
Yeah. So you're asking about the risk of accelerating the disease. So there have been conflicting reports on that. There have been conflicting reports, I think. we don't know yet if it's true that by surgery we accelerate or we increase the risk of an acute exacerbation, right? So what we know so far, and that's as whole is on theoretical basis, like promoting the circulation of fibrocytes, which are derived from bone marrow, can increase the risk of acute exacerbation. So far what's happening in many centers is that we have been seeing that we need to discuss the patient with our surgeon, with the anesthesiologist. We don't need to have very high flow of oxygen, and we need to use low pressure when we ventilate this patient during surgery, because clearly the mechanical stress and the oxidative stress during surgery can be a promoting factor for an acute exacerbation. So I personally do not think that surgery per se is increasing the risk of acute exacerbation, but I think that the way you are performing surgery, it may increase the risk. So that's why we always talk and discuss the surgical protocol with the anesthesiologist and with the surgeon before getting the patient to surgery. And so far we have not seen an increase in acute exacerbation.
I want to ask about cases which is not typical for UIP, but possible UIP, like reticular. Is there still like a role of steroids in such cases, or you're not even bother trying steroids in such cases? So not typical UIP, but possible, like fibrotic NSIP or something like that.
So the point of the colleague is that when you have a patient with a possible UIP, is there any room for using corticosteroids or immunosuppressor? The fact that you don't know the diagnosis actually is making things a little bit more complicated. So my suggestion would be in line with what Jean-François told before. Anytime that you have a patient with possible UIP, you do your best to get the diagnosis. That means you do your best to do a surgical lung biopsy. And with that, you'll get the diagnosis. In some patients, it's impossible to get a surgical lung biopsy because they refuse the surgery or because the surgeon don't feel that is confident. The patient maybe is too old, is too frail. In these patients, in my opinion, but it's a personal opinion, a trial of corticosteroids and immunosuppressor is worth trying. Because you will know that in 50% of them, about 50%, you will have an SAP, which may respond to corticosteroids and immunosuppressor. Again, what is important to consider is that since you don't have the diagnosis, it's important that your therapy is a trial of therapy. You do not go forward with corticosteroid for 2, 3, 4 years if the patient is not responding. So my suggestion would be a trial of 3-6 months of corticosteroids and immunosuppressor to reassess FVC, to reassess CT scan, and to see if there is any ex juvantibus data showing and suggesting an alternative diagnosis to UIP.
Thank you for this informative lecture. Sometimes we face different scenarios in our patient. I mean, sometimes we see clubbing, which we would like to see in such patients. Sometimes we don't see clubbing. Sometimes we see overlap with emphysema. Sometimes we don't see overlap. Sometimes we see unilaterality of the disease, not by the classical bilateral fibrosis. I mean, all these different scenarios, do they point to something in IPF, or do they are they phenotypes? Are they something different, or what are they exactly?
I think they point to something, but we don't know at what they are pointing. So just remind that the definition, even the definition of the disease, is extremely non-specific. So we are talking about idiopathic, so that's a negative definition. We don't know the cause. It's pulmonary and it's fibrosis. So it's very poor as a definition. It's very non-specific. At the same time, even the UIP pattern is non-specific of IPF. You can find UIP in asbestosis, you can find UIP in scleroderma, you can find UIP in drug-related disease. So I think that you are pointing to the fact that more than different phenotype, we can also have different disease there. But we are not there yet. So far we need to keep all of these patients under the same umbrella of IPF, and it's still possible that in 3, 4, 5 years from now we'll have different entities with different prognosis and different treatments, but we are not there yet.
Final question, final.
Thank you, Professor. Actually, two maybe quick questions, but one of them is probably comes from my anxiety about lead time bias. I mean, now with the advancement in technology, the high resolution CT scans have changed the landscape of interstitial lung disease, and the technology is progressing. And because of that, I think there was that discrepancy in the interpretation, even by expert radiologists, putting a kappa value of 0.6, which is a bit alarming, I guess, especially in countries where we don't have dedicated expert radiologists that would just do nothing but interstitial lung disease. Do we know what a very, very, very early IPF patient's lungs look like? I mean, we have to have honeycombing to make it a definite. But if we wait for honeycombing to become confident that we're making the proper diagnosis, we may be a bit late. The question is, do we have any idea about the primordial injury that would lead to honeycombing, or should we, when we suspect, making it probable or possible or whatever, to wait until we have honeycombing and then go back and revisit the issue? Because that puts the patient at a risk of progression that may not be recuperable. Yeah. And on top, of course, what you taught us about the overlap problems, especially with COPD, and we have a population that is extremely heavy in smoking habits. So we're always going to have this major bias of centrilobular emphysema that would cloud the picture. Yeah. So your comment, please.
That's a very good point. So this is, I think, is the crucial step in diagnosis. As it was pointed by Jean-François Cordier, waiting for honeycombing is too late. That doesn't make sense. So I have a patient with the familiar history of pulmonary fibrosis. He presented to my clinic with the diagnosis, one radiological and one pathological of UIP, IPF in 2 brothers. And he was the 3rd brother. At that age, he was 48. I took a high-resolution CT scan, was completely normal. Lung function test, normal. He wanted a surgical lung biopsy. And the surgical lung biopsy was UIP pattern, typical. So that's maybe is not the best way of, but that tells you that certainly when we look at the CT scan with some early fibrotic changes, it's very likely, when you look at the pathology in that lung, you already have big changes. So I agree with you, waiting for honeycombing, it doesn't make sense. On the other side, you would want to reduce the risk of surgical lung biopsy. And there are 2 main areas that we are lacking now. Biomarkers. There is no biomarker for IPF. I don't know if we are going to have a biomarker specific for IPF soon. Maybe not soon, but maybe sometime. And the other one is molecular imaging. Molecular imaging has not been developed. The last one, which is to me is the priority one, as Professor Cordier pointed out in a couple of editorials with Vincent Cotten, is the role of lung sounds. So in any guideline on IPF, always tells you bilateral Velcro type crackles. They have to be present. But this has been seen as a non-specific, non-scientific, non-validated, non-systematic finding, which is not true probably. So I think that area in particular, I know there are groups working in that area, may increase the specificity of the diagnosis, and I guess it might be one of the critical steps for early diagnosis and even for screening of patients with IPF. I just want to remind that I encourage everyone to read a paper just published in the year J, right? Just out in the year J by Jean-François and Vincent, pointing to this topic. really, if you want to figure out and to find this patient, now that we have drugs available, it would be crucially important to focus not on honeycombing on high-resolution CT scan, but on early changes which include lung sounds, lung function, molecular imaging probably, and biomarkers.
Thank you, Professor Luca.